resulting in increased cortisol and pro-inflammatory cytokine markers. So the depression and diabetes link. So if you people who have depression at a risk of having type 2 diabetes, and also people who have type 2 diabetes also at risk of having mood disorders. So if you look at this from this particular paper, depression is common in diabetes. Depending upon when you look at it, it varies from 10 to 30%. And also depression is associated with worse outcomes in terms of mortality. It's nearly 2 to 3 fold increase in mortality. And it is under-detected for sure, mainly because of, I think when patient comes with a physical problem, the focus is mainly on a physical aspect of it, like getting their diabetes under control and also listening to, but the mental aspect is usually not given much importance in clinic, which is not very helpful. So prevalence of depression increased in diabetic versus no diabetes. So if you look at the prevalence of depression in patients who have diabetes and patients with no diabetes, and obviously you can see 1 year prevalence of depressive episode in diabetes is almost 3 times that of people who do not have diabetes. And also if you look at the primary care numbers, and it's 4 to 15% of major depression, 9 to 16% of other depression. And diabetic population, if you take the population as 15 to 30%, and this kind of prevalence, you can see how high it is. So if you look at the meta-analysis of these 42 studies from this paper, so the odds ratio, that is nearly double the incidence of depression among people with diabetes. It's more common in women than men. And also, if you look at the patients population, so the community samples, and if you look at the patients who are visiting the clinics, again, people who are visiting the clinics are the people usually have some problems. I'm sure these numbers are taken from Western countries where they have a distinctive primary and secondary care patients. May not probably reflect that much in Indian population, but usually if somebody is attending hospital, a secondary or tertiary hospital, they might have some underlying problem apart from diabetes or some kind of diabetes related complications. So that could increase the risk of having depression, as you could see from the number 32%, 20%. And also if you look at the self-reports and interviews, again there is some increase, almost 3 times. So depression is associated at every stage of diabetes continuum. So people who are at pre-diabetes stage, the odds ratio of nearly 30 to 1.37. So that's nearly 30 to 60%. In at diabetes, people who have diabetes nearly double. And suboptimal glucose control, again, it goes high. Odds ratio of somebody has complications, again, it is 300%. And mortality, again, 2 to 5, that is nearly 200 to 500% increase. So the common mechanisms for the depression and diabetes link. So there are some psychological process and there are some biological processes. And if you look at the psychological process, diabetes specific distress. So the fact that they have diabetes itself is a distressing on their psyche. Particularly type 1 diabetes, where they have to check so many times a day and they have to take insulin so many times a day, is very, very difficult to cope. And that does usually cause some mood problems and depression and impulse. Again, sometimes they have to control their urge to eat, and also some also can have problem with satiety. So there are so many things that interplay here in terms of psychological reaction for the fact that they have diabetes. On top of that, they all already have underlying biological problems such as excess cortisol, innate inflammation due to obesity, autonomic nervous system problems, and also some genetical issues with early life programming. And on top of that, the medications like antidepressants and psychotic depression. Some people are on psychotic drugs like risperidone. And again, when somebody is severely depressed, and the circadian clock varies, and this does not help in terms of cortisol. So lack of sleep and sometimes sleep apnea. So there are multiple issues here. So depression and type 2 diabetes, and again there are common things here as we spoke in the last slide. So this slide is no particularly different. Depression is common in type 2 diabetes patient and is associated with increased mortality. Only thing is treating depression alone does not improve glycemic control. So we need to realize that. So both depression and diabetes is associated with high risk for all-cause dementia. So if you look at this particular graph, as you could see, the odds ratio is high to start with and slightly gets better, but as the duration goes high and high and the odds ratio go on high. So the suggested mechanisms behind is increased inflammation, decreased insulin sensitivity. Also, lack of insulin as the diabetes, particularly in type 2 diabetes, as the duration progresses, the insulin, the beta cell death and the lack of insulin also goes high and high. So obesity doesn't help. So if you look at this particular slide, as you could see, diabetes, the odds ratio is around 1.1 to 1.2. Whereas when there is a depression added to that, and it goes really, really high. So in fact, depression has much more association uh, with high risk for all-cause dementia compared to diabetes alone. But once they combine, they have an additive effect, as you could see here. So the odds ratio is nearly 2. So diabetes and depression and dementia. So dementia affects nearly 60 to 10% of people above 65 are older, and obviously increases with the age. And depression estimated to affect 1 to 5% of older adults. Depression is common in dementia, 20 to 40%, and it is probable risk factor for both vascular dementia as well as Alzheimer's. So diabetes and depression exhibit a closely linked bidirectional relationship. 15 to 20% diabetics will develop clinical depression at some point. So depression is 2 to 3 times more common among diabetes compared to who don't have it. And comorbid depression and diabetes have nearly 2.7-fold increased risk for dementia. So depression doubled subsequent all-cause dementia risk. So a history of depression can cause increased risk of later developing dementia, and it is an independent risk factor for the disease. And the interval between diagnosis of depression and Alzheimer's was positively related to increased risk of developing Alzheimer's, and suggesting that depression may be a risk factor for Alzheimer's dementia. I think it is widely accepted, I believe. So meta-analytic evaluation resulted in pooled odds ratio of nearly double. So that's nearly double the risk if somebody has depression and the risk of dementia in the future. So obstacles to recognize depression in medically ill. So there are multiple reasons why people don't pay attention to the mood aspect of the patient, mainly because the physical symptoms sometimes, physicians look for medical causes rather than mental health causes. That's one possibility. And also, sometimes if they have serious medical illness, and it actually a masked, and also depression may be seen as part of the medical problem rather than as a consequence or as a separate problem. And also sometimes the presentation can be very vague in medical settings. So 1 in 5 primary care visits are for new symptoms with no identified cause identified. So in primary care, so people present with unspecific symptoms. They're usually, okay, we'll see you again. And people do not actually dig deep if there is an underlying mental health issue. So if you look at this particular slide, you could see that people, the only 2% of the people who have mental health issues were picked up on the first screening. Only in the second screening, and somatic symptoms, not diagnosed with depression with high somatizations. So you could see only in the second screening, some of them were picked up. I'm sure many of them are not even picked up in Indian setting because they don't actually think from that aspect. Majority of them focus on sugars and sugars and sugars. So 90% of depressed patients reported primarily somatic symptoms. So if somebody comes with chest pain, they get an ECG or get a referral to cardiology. Tachycardia, persistent tachycardia. You need to think why this person is having persistent tachycardia. Somebody comes and says they're unable to sleep. So it could be that they have very badly controlled sensory neuropathy, which may not be helping them to sleep. And also people who have chronic pain also have an underlying mood disorder. So, and some of these medications do help for depressions like duloxetine and gabapentin, which has norepinephrine SSRIs associated with it. So it's important that we at least pay attention to that and make an appropriate referral. So depression predisposes to diabetes. So the premorbid depression have 37 to 100% increased risk of developing type 2 diabetes, risk independent of obesity, activity level, smoking, alcohol consumption, and family history. Mean age of onset of depression typically predates the age of onset of type 2 diabetes, whereas in type 1 diabetes, as you would expect, that the onset predates the onset of depression. So the depression was diabetes morbidity. So if somebody is already depressed and they have diabetes, it doesn't help because they lack motivation to do any of the things that we expect them to do. On top of that, if they have diabetes complications, it is even more difficult. So depression as a contributor to diabetes morbidity and mortality. So the poor glycemic control and less adherent to dietary recommendations, less adherent to oral hypoglycemics, increased risk of diabetes-related complications. Again, it is often associated with diabetes vascular complications, particularly painful neuropathy, sexual dysfunction, and if they have retinopathy, if they can't see very well, or if they have nephropathy, having to have go to nephrologist all the time or having to have a dialysis. These things don't help in terms of their mood. Particularly physical ill health can have a huge implications on mood because of the lower quality of life. So depression as a contributor to diabetic morbidity and mortality, they cause higher healthcare costs because of obviously because they don't have good health, they have to pay more. And on top of that, if they have depression, the price could be much higher. So symptom amplification, patients experience more diabetic symptoms, experience even when controlling for diabetes severity. Depression may have worse course among diabetics, and relapse rate 5 times higher than non-diabetics when not on prophylactic treatment. So it's very, very important this person gets referred to psychiatrist and gets appropriate care from the mood point of view, because it will have again impact on the diabetes. If they have good controlled depression, it's very easy to treat the diabetes as well. So depression was diabetes mortality, as you could see from this slide. No diabetes, no depression. If you take the risk as one, but with the depression, the risk is slightly high. If you have diabetes, the risk is even more high, but if they have both, it is nearly 3 times. So sometimes people go into this vicious cycle of endless problems and spiral down. So if you look at it, depression, lack of motivation, poor management of diabetes, which has results in higher blood sugar levels. Again, that causes greater fatigue and lethargy, and also worsens the mood, and that causes more depression. So it just goes and goes on. So what can be done to reduce the development of dementia and diabetes? Blood pressure control, better control of diabetes, avoidance of hypoglycemia, or using statins, or treat depression, or emphasis on cognitive function assessment. Well, does treatment of diabetes make a difference? Prospective study of type 2 diabetes and cognitive decline in women aged 70 to 81 years, nurses health study in US, showed women with diabetes who are on oral hypoglycemic agents performed similarly to women without diabetes. So they are getting treatment. Well, we cannot say because of that they are scoring better, but again, that definitely has some positive impact compared to people who don't. So women not using medication had the greatest odds of poor performance. So it could also be interpreted as the underlying depression may be causing this problem. So we don't know. So women with type 2 diabetes have 30% greater odds of poor cognitive function than those without diabetes, and there is an increase of 50% after 15 years of diabetes. So if you look at here, the number of hypoglycemias and the depression, as you could see from top to bottom, as the number of hypoglycemic episodes goes high and high, the odds ratio also goes high and high. So even additionally adjusted for 7 years mean HbA1c diabetes treatment and years of insulin use, even after additionally adjusted for comorbidities, there is a significant increase of odds ratio from 1.2 to 2, and again same even after adjusted for HbA1c and insulin use. So individualizing the HbA1c goals. This is probably the most important aspect of diabetes management. Often we see people get FBS and PPBS targets, and they interpret their diabetes control based on FBS and PPBS target, which is absolutely wrong way to do it. And they should be informed. They should not look at FBS and PPBS target. Particularly, they do the blood test on their own, go to a lab and look at the reference values and keep coming back to the doctor to make them into the reference range. That does not help. We need to individualize the target based on their comorbidities, and the best way to do that is HbA1c. And particularly if the people have very bad comorbid conditions such as cancer, or somebody who's on palliative care and who's going to die within the next few years, and severe heart failure, severe renal failure, cognitive impairment like advanced dementia. So, or somebody who has hypoglycemic unawareness, or somebody who is living on it on their own with a history of falls. We don't want them to give a very tight diabetes control and put them at risk of having a fall and put them into harm's way. So in those patients, we may have to control their osmotic symptoms rather than trying to get the best control, because it's very, very unlikely they're going to live long enough to have diabetes-related complications. So HbA1c has to be adjusted accordingly. So adverse effect of dementia diagnosis and management of diabetes, you could see if somebody has dementia, they're not doing very well. So as simple as that. So thank you very much. And next I will pass this my presentation next presenter to Dr. Krishnadas, who will be talking about this in more detail. So,
hello.
I think Dr. Krishnadas, it's your turn next.
Yeah, this is Dr. Krishna Das. Uh, uh, I'm a private practitioner in Vijayawada, working in Krishna Neuropsychiatric Center. Can you see the slides now?
No, actually. Can't see the slides. I think, have they given you sharing option?
Yeah. Okay.
Hello.
Hello.
Is there any issue, sir?
Yeah, this sharing slides.
So first of all, please open the slides in the backend.
Yeah.
And now click on the share screen again.
Yeah.
Click on the share screen button.
Yeah.
Yeah. And can you see your PPT?
Yeah.
Click on that. And after that,
Now you can see.
click on share button, sir, which you can see in the right bottom corner. After clicking on the PPTs,
Hmm. Yeah. Green button, share screen.
yes, sir.
Yeah, I have done it.
First of all, click on the green share screen button.
Yeah, I have done it. I have done it.
Okay. Can you see your PPTs?
No, no, no.
I have the presentation. I can share if you want to.
No, sir. This is prepared by me.
Sir, open the PPTs in the backend, sir. First of all, open the PPTs in your desktop.
Yes, yes.
And now come back.
Yeah. Yeah, I have done it.
Okay. Click on the share screen.
Yes. Okay, otherwise I'll proceed. Okay.
So try again.
Okay.
Try the last time. Clicked on the share screen.
Yeah.
Can you see the PPT slides which you see in the backend, which you opened
No,
in?
no, I can't see. No, no,
Can you
no.
see application window?
Yeah, application window is there.
Yeah. Click on that.
Yes. Yeah, yeah,
Share and now share
yeah.
your full screen. Yeah.
Okay. Okay.
Okay.
Yeah, this is Dr. Krishna Das. I am a private practitioner in Vijayawada, practicing in Krishna Neuropsychiatric Center. Yeah, a very warm good evening to everybody. So, so the physician is asking the patient, are you depressed because you have diabetes, or is diabetes causing you depressed? So the patient is answering yes. Yeah. See, many of us in the society, they because of lack of awareness of psychiatric diseases, they think that the psychiatric symptoms are they are a personal weakness, or it is some black magic being done on them, or uh, some kind of evil eye on them. So they think in these perspectives. Otherwise, rather than thinking in that it is something happening in our brain, or some neurotransmitters are affecting, and because of that they have these kind of symptoms. So most of the people in the society, they don't know, including our physicians also. Uh, See, so some of the medical disorders can cause psychiatric problems. Example, hypothyroidism as a biological cause of depression, or some tumors in the brain, or hyponatremia causes delirium. So some kind of medical disorders also causes psychiatric disorders. Coincidence of common conditions such as diabetes and depression may coexist in the same patient because both are prevalent in the population. So depression is a common disabling disorder. 10 to 15% of the population suffer from depression during their lifetime. So depression is more common in women. Why? Because of the hormonal problems. The depression is more common in women and in elderly. So depression in elderly, we should be very cautious. Why? Because in elderly people, they have masked depression, because if some elderly patients comes to me, and if I examine the patient, or when I'm interviewing the patient, so the patient might be having more than 60 years, and I am aged 37 years. If I ask the patient, are you depressed, are you having low mood, so because of the age difference, the elderly may try to avoid that question or skip the question, and if we are he may give the wrong answer. Why? Because see, I am of low age than him. So in that the interview should be different. Why? So the previous activities, you are able to enjoy it, or you are having the pleasure in it, or while watching the movie, or when you are seeing some comedy channels, are you able to enjoy it? So the interview should be different. Like, it should not be like, are you feeling low, are you depressed, rather than that we should be, why? Because in elderly, they may mask the depressive symptoms. That is why it is called masked depression. So the depression and diabetics, it depends upon all these factors, patient related factors. See, patient related factors means, so they may not be aware that they're having depressive symptoms because of lack of awareness of psychiatric problems. And the illness related factors, it may be in depressed diabetics, the sugar levels are not in control the level, so because of it they may have so many diabetic complications. And treatment related factors means too many medications, and medication related side effects, and family related factors. This is very important in psychiatric diseases, because see, if the patient is having depressive or some psychiatric problem, family members thinks that, this fellow had all, physically he's fit, why this fellow is doing all these things. So family members think in the same. See, even though they are educated, I can give you one example. I have one patient in Vijayawada. Husband is a auditor, and they have one son and daughter. Both are software professionals. So uh, whenever the female patient, she is having depressive symptoms, she has depressive symptoms for 3 to 4 months, and she had severe decreased psychomotor activity. Whenever she comes to me, she tells that, I want to open my eyes, but how much I try, I can't open my eyes. So because the brain will be active, because of this lack of decreased psychomotor activity, patient can't open the eyes, they can't do work, they can't eat, they can't bath, they can't brush their teeth. they can't comb because of this severe psychomotor decreased psychomotor activity. So it is one of the clinical feature of depression. So but family members think that she's totally okay, her legs are working, hands are working. Why? And they used to physically abuse both father and son. They used to physically abuse her. So once we treat the depression, and once she is out of depression, what the patient thinks, I have given birth to my son, but when I am depressed, he physically abused me, he kicked with me legs, he has beaten me so badly. So that mental trauma we can't erase. Why? Because of depression, she has done like that, but they didn't understand and they physically abused her. So family support is very, very important. And psychosocial factors, low socioeconomic status also. So this is common pathogenic mechanism and the interrelationship between both diabetes and depression. So in depression also we tell that exogenous depression and endogenous depression. Exogenous depression means depression caused due to external factors like family stress, or work stress, or social stress, economic stress, so the financial stress. These are all external factors. So because of that, poverty, childhood adversity, and poor health behaviors causes obesity, and intrauterine environment, fetal malnutrition, or fetal or maternal stress. These are common interrelated biological pathways: epigenetic changes, hypothalamic pituitary adrenal axis dysfunction, inflammation, and sleep or circadian rhythm disruption. So this causes insulin resistance or hyperglycemia. In one way, it causes affective disturbances and altered brain neuroplasticity, which causes depression. And the other is cognitive impairment or altered brain neuroplasticity, which causes diabetes. So this is the interrelationship between diabetes and depression. So this is one important slide. So depression, it has emotional symptoms are sadness. Sadness means it should be pervasive sadness. That is very important. It means feeling low for 1 hour or 2 hours, not like that. In a day, the sadness should be most of the time. That's why it is called pervasive sadness of mood, or loss of interest in work, or loss of interest in pleasure, anxiety, guilt, anger, mood swings, irritability. So the thoughts is self-criticism, impaired memory. So in depression, so many of the patients say that forgetfulness. So forgetfulness is because of decreased concentration and decreased attention due to depression. It is not dementia. So chronic fatigue. More than 50% of the depressed patients, they have physical symptoms like headache, or chest pain, or abdominal discomfort, or muscle aches, pulling sensation of neck, or pulling sensation of hands and feet. So here it is mismatched between depression and diabetes. Why? Because diabetic patients also have this chronic fatigue or muscle aches and all. So here we should differentiate weight gain or weight loss. See, depressed patients, they have eating disorder. Why? Because to come out of the depression, patients, what they tend to eat much more. See, we see in this kind of symptom mostly in female patients, young female patients. See, they have depressive symptoms. They don't know that they have depression, but they come to us for eating disorders. So they tend to eat too much to come out of the depression. The same thing happens in males also. They consume alcohol. Why they consume alcohol? So it is called self-medication. To come out of the depression, to elevate themselves, they take alcohol, or they smoke, or they take cannabis, or they take some opiates. Why? Because they're so depressed, they self-medicate themselves to uplift their mood. So whenever they consume alcohol for some duration of time, they feel happy, they come out of the depression. So if we have to see, whenever a person comes with substance abuse, so we should see underlying what is going underlying. So the same thing happens with anxiety also. So many of them, to come out of this anxiety, they take alcohol. So whenever a patient comes to us with substance abuse, so we should evaluate them psychologically why they are taking these substances. So And suicidal behavior, this is very, very important. Why? Because in clinical setup, we tend to avoid this the death wishes or suicidal behavior. And again, we should differentiate whether the patient is having death wish or suicidal ideas. So this slide is important for treatment options. For in serotonin deficiency, they have that decreased libido and yeah, decreased appetite and aggression. In norepinephrine, decreased attention and concentration, decreased interest in work or decreased interest in pleasurable activities, decreased psychomotor activity. And this for both serotonin deficiency and norepinephrine deficiency. This is very important. Why? Because depending upon the symptoms, you can give SSRI or SNRI. And this is the slide showing why the patient have physical symptoms. So serotonin norepinephrine dysregulation causes emotional symptoms like low mood, lack of interest in work and all. And the same thing in the spinal cord causes this pains. So somatic symptoms or physical symptoms. In outpatient department in general hospital setting, this is the prevalence of depression. In outpatient department, in all the departments, the prevalence rate is 2 to 15%, and inpatient 12%. Diabetes, it is 10 to 30%. Stroke, so and post-stroke depression is so much literature is available, and it is between 20 to 25%, and cancer 18 to 39%. Myocardial infarction, post-MI also there is so much literature available. Post-MI depression, it is 15 to 19%. Rheumatoid arthritis 13%. Parkinson's disease 10 to 37%. Irritable bowel syndrome 21%, and COPD 16%. Studies suggest that people with diabetes who have a history of depression are more likely to develop diabetic complications than those without depression. People who suffer from both diabetes and depression tend to have higher health care costs. Why? Because the treatment cost is more. And it is people with diabetes, their families, friends, and even the physicians may not distinguish the symptoms of depression. Prevalence rate is around 9 to 30%, and depression generally precedes diabetic symptoms in type 2 diabetes. This is the reason why young adults between 25 years to 40 years, there are more diabetic cases because of depression or stress. Why? Because there is increased expectation from the society and from the family. So in other psychiatric disorders like schizophrenia and bipolar affective disorder, the disease itself causes metabolic syndrome. In schizophrenia, the patients are obese, they have diabetes or hypertension, or increased cholesterol levels, or increased risk for myocardial infarction. Why? Because the disease itself causes metabolic syndrome. Previously, researchers or physicians, they thought that it's all side effects of medication, but disease itself causes metabolic syndrome. Among depressed in type 1 diabetes, there is 19% worse glucose control. In type 2 diabetes, 16% worse glucose control, and the HbA1c levels in depressed patients are between 2 to 3%. Stress and genesis of diabetes. Stress can produce transient suppression of pancreatic cell function and alter insulin sensitivity. Cortisol released during stress may increase plasma glucose by antagonist impact on insulin-mediated inhibitor of hepatic glucose release, decrease glucose utilization in muscles, reduce the binding affinity of insulin receptors. So, in depressed patients, the cytokines, interleukins, and TNF are increased. Because of this, they cause sickness behavior and have physical symptoms like fatigue, anorexia, anhedonia, decreased psychomotor activity. In depressed patients, in diabetics, they have recurrent hypo or hypoglycemic results, which causes changes in the limbic area, and which is prone to depression. Depression may accelerate coronary heart disease through its effect on sympathetic activity, platelet activation and aggregation, heart rate variability. So, how depression affects diabetics? It worsens glycemic control, accelerates the development of diabetic complications like retinopathy, nephropathy, sexual dysfunction, macrovascular complications, decrease compliance with medication. Why? Because depression, they don't have self care. uh, they tend to postpone. So when they remember that we have to take medication also, they take after some time, then they think that okay, let us take tomorrow. If we don't take medication, what will happen, let us see. So this kind of negative thoughts will be there in the depressed patients. So that is the reason we have to treat depression. And they follow irregular food habits. They don't have physical activity. And depressed patients are prone for coronary heart disease, significant impairment in cognitive functioning. So why many psychiatric diseases like depression or psychosis or anxiety, these patients, they have cognitive impairment. And in mania, and it is very different. Mania, they are mania people are very intelligent and they're very overactive. But some other psychiatric diseases, they have cognitive decreased cognitive functioning. Because of that, they have this forgetfulness, decreased concentration, decreased attention, decreased quality of life. And this is also important. Depression and diabetic healing of wounds. Yeah, there is a study. Patients with depression, they have the poor healing of wounds. Correlation between depression and diabetes mellitus. Depression causes increased release of counter-regulatory hormones like catecholamines, glucocorticoids, growth hormone, and glucagon, which in turn decrease action of insulin and increased insulin resistance. It causes depression-associated insulin resistance, or the other way, increased blood glucose levels. Depression causes increased morbidity and mortality, increased the risk factor for stroke, myocardial infarction, in death, and death in elderly hypertensive patients. 4 times higher rates of cardiac mortality in patients with acute MI, increased mortality in elderly patients with or without baseline cardiac problems. Major depression has risk factor for diabetes mellitus and coronary heart disease. Bipolar disorder and diabetes, they have both have genetic origin. BPID is associated with obesity and type 2 diabetes, associated with more severe course of illness and rapid cycling. So bipolar affective disorder and diabetes, they have this rapid cycling. Rapid cycling means depression or manic episodes in a year. If there are more than 3 episodes, either depressive episodes or manic episodes, if there are more than 3 episodes in a year, it's called rapid cycling bipolar. So some antipsychotics causes weight gain or increased blood glucose levels. They are clozapine, olanzapine. Clozapine and olanzapine, both the drugs can cause drug-induced diabetes. So when we have started these drugs, and if the patient, if we found if the patient is having diabetes, then we have to stop these drugs and see. And if in early stages, if we stop these drugs, we can prevent the patient from diabetes mellitus. So this is also very important. Why? Because when we start clozapine and olanzapine, and if we see the blood glucose levels are higher, we have to stop these drugs. But the bad thing in our psychiatry is, whenever we order any investigations, patients, they don't like it, or they don't try to do these investigations. Why? Because when we order some blood investigations, they tell that, doctor, we have come for some brain problem, and why you want blood tests? So if you try to convince them also, they don't understand. Why? Because whenever we start clozapine, we have to do investigations. We have to see total count and differential count every week for a period of 3 months. But patients don't accept. And lithium, valproate, and risperidone, among these, valproate causes weight gain. Lithium and risperidone are very less. And lamotrigine, aripiprazole, and ziprasidone. Whenever we see that patient is having weight gain, or their sugar levels are uncontrolled, we have to go for these drugs: lamotrigine, aripiprazole, and ziprasidone. High mortality is associated with depression and type 2 diabetes compared with non-depressed patients with diabetes. Sedentary lifestyle is significant independent predictor of mortality. Depression and sedentary lifestyle are bidirectionally related. Why? Because if the patient is having depression, they have decreased psychomotor activity. Because of that, they have a sedentary lifestyle. Both biological and behavioral factors are associated with increased mortality. Depression is associated with poor adherence to self-care regimens like diet, exercise, and cessation of smoking. So when the patient is having depression, they don't follow the regular eating habits and how much they are eating, what they are eating. They don't follow all these things, and because of decreased psychomotor activity or psychomotor retardation, they don't exercise or they don't walk. So to uplift themselves, they self-medicate with smoking or alcohol or other substances. Mortality may be due to poor glucose regulation based on HP abnormalities and increased risk of myocardial infarction and stroke. So sexual dysfunction and diabetes, this we see very commonly. Whenever physicians also, whenever we come across sexual dysfunction, only one thing will be there in our mind, that male sexual dysfunction, but we don't ever think about female dysfunction. So, and many a times we see in OPDs also, if the male person is having some sexual dysfunction, uh, the female and female parents, they come to us and say that, see, our son-in-law is having sexual dysfunction or erectile dysfunction, is unable to perform, whether we can go for treatment or whether to go for divorce. But when do we ever seen, have ever seen a male patient's parents come and see that my daughter-in-law is having sexual dysfunction? That is the difference. Why whenever we the sexual dysfunction word comes in the public or in our mind, we think only female dysfunction. Nowadays we are seeing so many female sexual dysfunction patients, but we neglect these things. Why? Because in our interview itself, we don't ask for their sexual performance in our interview itself. So there is threefold increase in erectile dysfunction. Erectile dysfunction is correlated with obesity, smoking, and high glycosylated hemoglobin. Longer duration of diabetes mellitus and presence of complications are also associated with ED. Depression and anxiety worsen ED. Why? Because in depression they don't have desire. So without desire we can't do anything. So if we treat depression, patient will have desire and they can perform. And anxiety. So in erectile dysfunction or premature ejaculation, the main cause for having ED, erectile dysfunction or premature ejaculation, is anxiety. If we can treat anxiety, the patient can perform wonders. So some antidepressant and antihypertensives are also responsible for erectile dysfunction. Pre-existing dysfunction should be evaluated. So added stressors are social, financial, and work-related stress. So high cost of medical management and lack of insurance. Work-related stress more in males. Communication difficulties with healthcare providers due to too little information and education about with their diabetes and depression. So what are the benefits of treating depression in diabetes? So if we treat the depression, they restore sleep and eating habits. Why? Because depressed patients, they continuously sleep. Sleep means they sleep on the bed and close their eyes, but they don't go to sleep. So that is important. And they have very poor eating habits, are eating more or eating less. Increased social, occupational, physical, or other behaviors. Relief of pain and increased tolerance for pain. Improved ability to cope with illness. Decreased preoccupation with somatic complaints. Enhanced sexual functioning. Improved adherence to treatment regimen. Goal of treatment: decrease depressive and anxiety symptoms, restore normal sleep and eating. Behavioral action: pain relief, improve coping and function, decrease somatic preoccupation, enhance sexual function, improve adherence to plasma control. So basic principles of treatment. So in diabetes with depression, in diabetic patients, most of them, they complain of somatic symptoms, muscle aches or pains or heat sensation of body, a burning sensation of body, or tingling and numbness, or neuropathic pain. So in diabetes or depression, these somatic symptoms are very, very common. They say that they come to us and say, I have heat sensation of body, some heat is coming out of my body. And when they're urinating or defecating also, they say that it's heat sensation while urinating or defecating. So these kind of symptoms are very common in depression. So whenever patient complains of these kind of symptoms, we generally go for tricyclic antidepressants. But uh, tricyclic antidepressants, they improve the symptoms, but the other thing is they cause insulin resistance, they increase blood glucose levels are higher, and uh, TCS, they cause weight gain, and they cause they impair memory. So these kind of side effects are more with the tricyclic antidepressants, and tricyclic antidepressants are contraindicated in cardiac patients. So the other treatment options are SSRIs like fluoxetine, sertraline, escitalopram. So these are and in eating disorders, sertraline works very well in eating disorders. The only antidepressant shown to be safe and effective in post MI patients is sertraline. So psychotropic medications that may cause weight gain are antipsychotics like clozapine, olanzapine, risperidone. So clozapine and olanzapine are the drugs which cause more weight gain. The others are very less, like quetiapine and other first generation antipsychotics. Antidepressants which cause weight gain are amitriptyline, mirtazapine, and very escitalopram. They say it's rare, and other mood stabilizers are divalproxodium. Sodium. Psychotropic medication that may cause glucose and lipid metabolism are clozapine and olanzapine. They're worse. Increased effect of the antidiabetic agent on blood glucose possibility effect. So psychotropic affecting metabolism are fluoxamine, paroxetine, and sertraline, and drugs affect are glyphosate and tolbutamide. Uh, which induce metabolism are carbamazepine, and drugs affect are glyphosate and tolbutamide. So in any psychiatric diseases, the role of family is very important. So rather than the patient, we should educate the family members why we are treating this patient, why treatment is required, and for how long treatment is required. So whenever a patient comes to a psychiatrist, more than a patient, we should educate the family members that what is the diagnosis, why we are treating, why treatment is important, for how long treatment is important. Why? Because if the patient comes with depression, if we start treatment, patient improves in 3 weeks. What patient or family members or neighbors think that, so patient is improved, why he requires further treatment? So it is a common for any human being. See, once we are improved, so we don't require treatment. So it's a common human psychology. So that is the reason we should tell that we should be in till the patient improves. Why? Because in depression we have to treat with the patient for a duration of 4 to 6 months. So if the patient is having anxiety also, we have to treat the patient for 4 to 6 months. If the patient is having psychosis, it's more like we have to treat the patient for 2 to 3 years, or it's more. So it is very important for us to educate the patient's family members. So emotional support and understanding family members. So non-pharmacological interventions are also very important. Why? Because why only some patients are having depression? Why only some patients are having anxiety? See, psychosis and bipolar affective disorder, so they are all different. They are all genetic origin. So we have not much to do with non-pharmacological interventions. But anxiety, depression, stress, so we can do wonders with non-pharmacological or psychosocial interventions. So why only some patients are having depression, or why some patients are only having anxiety? Why? Because because of their personality. So they have anxious personality, or they have very poor coping skills. So we have to focus on their personality. We have to focus on their coping skills. So if we improve these coping skills, so they will be out of depression, or they will be out of this stress or the anxiety. So these are all very important. Cognitive behavioral therapy. So cognition means thought. So if you change the thought process, their behavior also will be changing. So there are many studies that when the patient is diagnosed with diabetes, they initially started that there are studies that so these diabetic patients, they are prone for depression or anxiety or some kind of stress. So instead of going for full-blown depression or anxiety symptoms, why can't we prevent these psychological aspects? So they tried non-pharmacological interventions for diabetes patients without depression or anxiety, but the studies have shown that there are the results are not good. So when the patient is diagnosed for depression or anxiety, then we can start for this. Apart from medical management or without medical management, also we can start this non-pharmacological intervention like cognitive behavioral therapy or exposure responsive therapy. Uh, Dialectical behavioral therapy. So peer and family support is very important. Psycho education about the illness, activity scheduling, problem solving skills. So because of these problem solving skills also, they tend to have these depressive symptoms or anxiety symptoms. So we should focus on this problem solving skills, communication skills training, and goal setting skills. Individuals with diabetes should be regularly screened for subclinical psychological distress and psychiatric disorders. So psychological interventions like motivational interventions, stress management strategies, coping skills trainings, and family therapy, these are very important. So whenever patient comes to for diabetic management or depressive management, so we should tell that family should have quality time. Quality time means we should have some time in a day, in 24 hours. At least we should have 1 hour for our family. So where we can discuss our feelings or our emotions or our thoughts freely to the family members. So there you should not have what financial stress you are having, what you are studying, what is your rank in your school, what is your rank in your college. So these kind of things should not come in this quality time. So that we should give our family members, they should express very freely. So this is very important in each and every family. And for working men or working women, time to self. See, many people who are doing wonders in their work, they tend to have substance abuse. They at the end of the day, they go and they booze. Why? Because they don't spend time for themselves. They don't invest time on themselves. That is the reason why they find relaxation there. They find mental peace at the bar. So this is very important. Spending time to self and quality time. Quality time means we should spend free time and we should express our emotions in front of our family. This is very important. See, when we see this picture, we think that they are having very good time, but they are spending their time with their mobiles, and so this is very important. See, when we can't express our emotions, when we can't express our thoughts, these kind of things will happen. This is one patient I have treated him. He's a farmer from Tenali. So he went into the bathroom every day with the shaving blade. He has cut his throat. So when patient is in ICU, when I was called for a psychiatrist opinion, when I'm talking to his wife says that every year during this period of time he will be low for 2 to 3 months, and the rest of the year he's okay. So we thought that it is normal. Every year he's low for a period of 2 to 3 months. The rest of 9 to 10 months he's fine. He does his work. So it is a classical seasonal affective disorder. Seasonal affective disorder means in a year, for a period of 2 to 3 months, patients presents with depressive symptoms. The other year he is okay. So it is very rare in India. Why? Because seasonal affective disorders are very common in cold countries. In my experience from 2010 to 2020, I have seen barely 5 cases of seasonal affective disorder, and treatment is very simple. If you give one tablet of bupropion 150 mg, patient improves. So why these things happen? Why? Because patients has we don't tend to share our emotions. We don't tend to share our thoughts. So because of our busy time, or so this is very important. When our patient comes to us, we should educate them that You should have quality time. You should share your thoughts. You should share your emotions to your family members or your friends or well-wishers. So this is important. This is also part of our therapy. Thank you. Thank you very much.
Excellent. I think that was a very nice talk, Dr. Krishnadas. It was very eye-opening to me as well.
Yeah.
I didn't know
Thank you, sir.
Schizophrenia itself is a metabolic syndromic state.
Yes, sir.
Yes, it was true that I was thinking that this the medication that causes them gain all these problems, dyslipidemia, weight gain, diabetes, and all.
Yes.
It was a very eye-opening session for me, at least.
Thank you, sir. Thank you, sir.
Thank you so much for your talk.
Thank you, sir.
Sir, there are some questions from attendees. Can I read it?
Yeah.
One
I
question
have one
from
question before I let the audience ask. Let me ask. I got hold of Dr. Krishnadas, so I need some. I have one question for him. So, one thing that was very interesting to me was one presentation. Usually, most of the diabetes neuropathy, since I'm talking about painful sensory neuropathy, the first line recommendation is duloxetine.
Yes.
Some guidelines also say to use nortriptyline or imitriptyline with the combination of gabapentin or pregabalin.
Yes.
It was interesting to note that these are not very good for diabetes.
Yes, sir.
And you mentioned sertraline also is useful
Yeah.
in painful sensory neuropathy and is also better in terms of diabetes and insulin resistance.
Yes, sir.
So, could you give some light on use of sertraline in patients with the painful sensory?
Yeah. Generally, what we do is sertraline we use in a dose of 25 mg or 50 mg, maximum 50 mg. It is our routine practice. But sertraline in a dose of 150 mg to 200 mg. See, sertraline we can go up to 300 mg, but we rarely try. So if you go up to 150 mg to 200 mg, these sensory symptoms are motor neuropathy or sensory neuropathy. These kind of symptoms will tend to reduce. The one thing is with gabapentin or pregabalin, we usually use, but the thing is patients have habitual formation for these molecules. If they come for regular follow, it is okay. But most of our patients in Indian setting, they don't come for regular follow. They come visit in once in 6 months or once in a year. So at that point of time, it's very, very difficult for us to remove these drugs, pregabalin or gabapentin.
So sertraline is what you would recommend in terms of.
Yeah, sertraline and duloxetine is also a very good drug, sir. But for duloxetine, they have GI symptoms.
Yeah, because the duloxetine usually we used to use in foot clinics, and I mean obviously we don't have dedicated foot clinics here. When I was in England, we had this dedicated foot clinic. So we used to start with 30 mg, go up to 120 milligrams. And here people don't have patience. You
Yes, sir.
give a drug, within 1 week, it should go like that. So there's no place to titration. It has to go.
It is psychiatric drugs. We have to go very slowly, sir. Indefinitely. See, if the patient don't turn up, also why? Because, sir, see this SSRIs in duloxetine. Some patients we don't know. 1 in 1,000, they tend to have seizure disorders. They come with seizures, or we rarely hear that. Actually, very recently, one of my patient from Padikakani, she's having depression from very long, 10 to 20 years. They are from farmers background. Everybody went to farming. This female patient is at home. So by the time they came back, she had that tongue bite, this lips bite, and she died. So we don't know the seizure threshold. We don't measure for each and everybody. So SSRIs, every time we should be cautious that this patient may have seizures. So this is very, very important. So that is the reason why we should go very slowly, 25 mg, 50 mg, 75, 100, like that. Why? Because when we are increasing the doses, patients come. Meanwhile, they tell, sir, suddenly this time I have jerky movements while sleeping, jerks. So that means this patient is prone for seizures. So at that time only we can reduce the dose, or we can add clobazam, or we can add some valproate, so that we can prevent seizures, sir. So that is very important, sir, in psychiatric medications. So the patients clearly tell that, sir, these days I am having jerky movements during sleeping. Suddenly some jerks are coming. So that means this patient is prone for seizures.
No
So
problem.
some patients have decreased seizure thresholds.
It's a
Very
very
important, sir.
nice explanation. So you can go ahead with the audience questions. So I have
Yes,
privilege being another speaker to have a first question.
yes. Sir. Thank you, sir.
Okay, sir. So, one question from Dr. Gangadharan R from Andhra Pradesh. Does
Yeah.
depression lead to diabetes?
Yeah, definitely. Why? Because in depressed patients, these glucocorticoids are released more, and they have very poor eating habits, poor self-care habits, or they have psychomotor retardation. They don't do physical activity. So because of all these things, depressed patients, they are more prone for diabetes.
Okay, so next question from Dr. Krishna Murthy S from Telangana. Which are the
Yes.
safe medicine for treatment on depression in diabetes?
Yeah, SSRIs are more safe. So whenever we are SSRIs means anything, fluoxetine or sertraline or escitalopram. So any drug we have to start slowly. Fluoxetine when we are starting. See, again it depends upon the symptoms. If the patient is having severe psychomotor retardation means, see they want to do everything. So I should get up, I should cook for my family, I should take care of my children, I should take care of my husband. So these thoughts will be going in their head, but they can't move their hand, they can't lift their hand. Why? Because they have that psychomotor retardation. So they want to do it mentally, but physically they can't do it. So in such a patient, fluoxetine does wonders. So fluoxetine is that drug itself is called activating antidepressant. So depending upon the patient, we should select the medication. So if the patient is having severe psychomotor retardation, we should give fluoxetine. If the patient is having more anxiety symptoms, we should go for escitalopram. If the patient is having agitation, irritability, anger outburst, if the patient is having breaking household things, then we should go for sertraline. Why? Because sertraline controls aggression more. Escitalopram controls anxiety more. So depending upon the patient's symptoms, we should select the drug. And whenever patient is coming for follow-up, we should see for any sexual side effects or any GI problems. Why? Because patient having gastric ulcers, we should not give SSRIs. Why? Because SSRIs have the side effect like GI ulcers, GI bleeding is the side effect of SSRIs. So whenever patient is coming for follow-up, we should ask all those things. And if the patient is having a burning sensation of abdomen, we should stop the drugs. Why? Because GI bleeds is the common side effect of SSRIs. So these things should be in mind. If the patient is telling that I'm passing blood into my stools, so we should be aware that we should stop the drugs.
My feeling is if somebody has depression or suspicion of depression, they should simply be referred to psychiatrist. I don't think we do a justice by starting a.
Sir, see, this is very important, sir. See, whenever a physician say to the patient that if you refer that, go for a psychiatric referral, they usually tend to, "Arey, why this doctor is telling that? Am I a mad patient? Why this doctor is telling that I am mad?" So patient have that things. So the conveying should be different. Like better once you consult a psychiatrist and take in opinion, or let that colleague doctor be talk to me after evaluating you. So once you do 2 to 3 times, then they think that, why my family physician is telling to consult a psychiatrist. Okay, let us go and see. So why? Because uh, see, social and cultural aspects are very, very important in our daily practice also, sir. Once directly, bluntly say that go and see a psychiatrist, patient don't like the same the word itself.
Yeah, that's a nice way of putting it. Yeah, we need
Yes,
to
yes.
be careful about how we
Yeah,
put it.
yes, sir. Yes, yes, yes.
But the point is, we can't do justice in diabetes clinic in terms of assessing mood disorders. It will be very superficial, and
Yes,
we
sir.
will definitely make mistakes because we are not experienced to pick up those cues and decide on the medication who benefits from what. So the best thing
Yes,
is
sir.
there is a specialist. You are specialist for a reason. So I think if somebody has a mood disorder, they should see a specialist. That's what I mean.
Yes.
Mm.
So that was the last question. So,
Okay.
Thank you. Nice to see
uh,
you. Bye.
so can we conclude the session?
Yeah, please.
Okay, sir.
Okay. Thank you, sir, on behalf of organizer. Thank you for your insightful and educative talk. Thank you.
Excellent. Thank you. Bye bye.
We are ending
Thank you.
the
Thank you.
session.